So, hi everybody, it's Karen Joshi, gynae cases peer reviewer, talking to Dr. Monica Krishnan, our consultant gynae mentor, and today we're talking about abnormal uterine bleeding. There is a guideline on the portal that we might refer to that you'll be able to see, but I'm just going to sort of talk to Monica about abnormal uterine bleeding and some tips and pointers for when we're thinking about managing in primary care or referring. That's okay. So hi Monica. So I suppose, could we start by just defining what is abnormal uterine bleeding?
So hi everyone. So abnormal uterine bleeding is any bleeding that differs from a patient's normal menstrual cycle. So this could be changes in frequency, duration, or volume, and these can be placed within different categories. And the common things that we see within gynae are things like heavy menstrual bleeding, which we just don't consider as a lot of blood, but it should be interfering with quality of life, but sometimes even leading to anemia. You also get intermenstrual bleeding. This is spotting in between periods. The other thing to look out for is postcoital bleeding, which is quite common in the younger age group. And the other red flag is postmenopausal bleeding. You need to think about this as a spectrum from mild irregular spotting to significant heavy bleeding that affects a person on a day-to-day basis.
Okay, thanks. Yeah. And are there things that we should be thinking about checking before we move to referral? What sort of things should we be looking for?
That's a very good question. So there's several things that you can do in the primary care before making the secondary care referral. These are things that can be done quite easily. The first thing is the basics, which are the history and examination. So first things to look at is the pattern of bleeding. So to look at the frequency, the duration, and the amount of bleeding, to ask them how many pads do they change in an hour. So are they changing more than 2 or 3 pads in an hour? That's quite significant blood loss. Or if they're having to use multiple heavy pads, or if they're having breakthrough bleeding or flooding or with clots. We also need to check their contraceptive history, particularly looking at what pills they are on, or whether it could be one of the reasons why they could be having these irregular bleeds, and then to look at the symptoms that they have, especially if they have any anemic symptoms or any pressure symptoms, which could indicate they have like fibroids or a pelvic mass down there. The other things then to look at is, after history and examination, is to do investigations. The first thing to rule out in any premenopausal woman is to exclude pregnancy. So the first thing that we ask is for you to do a pregnancy test, and then to rule out infection. So this is just doing a basic pelvic exam and to do a triple swab. So that's the high vaginal swabs, and to check for chlamydia and gonorrhea. And then to do a basic pelvic exam, we're not asking anything more than doing a speculum and just a simple PV exam, so just to have a feel, see if you can see any fibroids or any ovarian cyst. But if you're finding it very difficult, then we suggest that you do an ultrasound scan at this point. We also suggest that you have a full blood count just to rule out anemia in these patients. And another key thing to look at is their BMI, so to work out their height and weight, because we know particularly with irregular bleeding, particularly with a higher BMI, there's risk factors for endometrial hyperplasia. So if you're worried and these patients are high risk, then you really need to do a BMI, because they're a higher risk of these patients. The other thing I would say at this point is that try and reassure patients, particularly if they're looking to move towards treatments, particularly hormone treatments, to say that if they have a normal scan, and if you've done any other investigations, if these are normal, they're more likely to not miss anything, and it's worth having a go with one of these treatments in the primary care before referral to the secondary care, because their chances of having endometrial hyperplasia or endometrial cancer is quite low.
Right, thank you. Yeah, and moving on, what can we try in primary care? What are the different management options that we can use before we need to refer to you?
So once you've done your basic assessment and you're happy with things that these can be managed in the primary care, the first thing that we suggest is to do non-hormonal medication. So the first thing to try is non-steroidals. This can help with pain and also help with bleeding reduction. Another great treatment is tranexamic acid. What we suggest is to use 1 gram 3 times a day between day 1 and day 5 of their periods. This helps reduction of bleeding, and it's very, very effective, especially in the younger age group. And then to look at hormonal options, the first, usually in the early 20s, we would suggest the combined pill, but obviously this comes with a lot of contraindications, just to be aware of them and make sure they fit the criteria to be prescribed. Initially, I would suggest to start them on a monthly basis, and then you can try cycle it to reduce the number of periods that they have a year. I sometimes even say for patients to carry on the pill until they get irregular spotting, and then to stop the pill for 4 or 7 days, usually 4 days, and then to restart again after that, just to reduce the number of amounts of cycles they have. The other options with the hormonal pills are the mini pill, so the progesterone-only pill, which is quite safe. But other thing that you can do with that is if they're getting that irregular spotting, particularly in the higher BMIs, you can double dose the pill to have more effective control of their bleeds and to reach the stage of amenorrhea. And another fantastic things we all gynecologists love is the Mirena coil, something that could be quite fitted easily at the primary care. And the other options are the long-acting contraceptive methods such as the implant or the depot. I tend to stay away from the depot just because of the risk of bone mineral density and the return to fertility, but if something that they want to use, then yes, more than welcome to use that in the primary care. But just to be aware that all these hormonal medications usually cause irregular bleeding in themselves. So it's really, really important, especially in the first 3 to 6 months, to counsel these patients to say that you will get these irregular spotting, but if they persist, to come back and let us know. But also worth trying to try different methods in the community before making our referral. So you can switch between the different combined pills. There are quite a few options. Not every pill suits every patient. Or if you're on a Mirena coil, you can try and you get irregular spotting, especially after in the first 3 to 6 months. You can try add on a mini pill or to try like a Provera on top of it or a tranexamic acid just to see where you are with it.
Right.
But if they have any persistent bleeding, then to refer after that point.
Yeah, right. And quite a few GPs can do Pipels in primary care. And I just wondered if we went over the indications for doing a Pipel and what we do with the results as well.
So it's fantastic that you guys can now do Pipel in the community. It saves a lot of referral into the secondary care because it's a quick, easy procedure to do. So what we usually suggest is for Pipel to do with any onset of any heavy menstrual bleeding that is different from their usual cycle, and also to do in patients with risk factors for endometrial hyperplasia, so that the patients with polycystic ovarian syndrome, patients with a BMI over 30, and NICE now has come and said that if they're over age of 40, you should be considering, and if they've got a change in the periods, then you should be considering doing a Pipel as well.
Okay, yeah. And basically normal results, because sometimes they come back with different sort of terminology. So proliferative endometrium, secretory endometrium, depending on the stage of the cycle, that classed as a normal result. Yeah. But any other than that, simple hyperplasia, complex, atypical, that should all be, just to clarify, that should all be referred if we get a result like.
So they have normal endometrium, so they have proliferative or secretory. These are depending on the stages of cycle, especially if they've been on hormones, this is what they will report as. These just are normal and they can just continue to be managed in the community. Abnormal findings, simple hyperplasia, you just need to do a routine referral to gynae. But if you've got anything more than that, like complex or atypical hyperplasia or EIN or cancer sometimes, which sometimes you find in the community, then these all need a 2-week wait to hysteroscopy.
Yeah, brilliant, thank you. And so obviously there are times when we will need to refer in, and I just thought it'd be useful to go over the criteria for when we should be referring and not managing in primary care, but referring on for more investigations. If we could just chat about that.
So the times when I would suggest that you refer is particularly if they've got any instrumental bleeding for more than 3 months or persistent or prolonged bleeding, if they've got any post-coital bleeding after 3 cycles, any postmenopausal bleeding, we are well aware of this now, that they all need an urgent referral, 2-week wait if they're postmenopausal or if they're under 60 on HRT. Also things to consider are tamoxifen users if they've had breast cancer and they've pass and they use tamoxifen for any reason, then these will need 2-week wait. Or if you tried any kind of hormonal treatments or non-hormonal treatments in the community and these have failed for after 3 months, then to refer these patients. For Marina, I would say just leave a bit longer, so wait for 6 months before you make that referral, because we know the Marina takes a longer time to settle in. And if they have any severe symptoms, so if they're anemic and you're not finding the cause and you can't treat it in the community, or if they have large fibroids which are causing pressure symptoms or fertility issues, or if they have any kind of submucosal fibroids or intercavity fibroids, so those are intramural fibroids which are then dropping into the submucosal component, then to refer these patients. Or if you have any other kind of pelvic masses that you're worried about, then to refer these patients on. Like I said, it's quite easy, it's quite common for irregular bleeding to happen on hormonal contraception. So unless they are persistent and ongoing or very heavy, I would wait for three months to see if it settles. If it doesn't, then to make that referral to the secondary care.
Right, yeah. And you just mentioned the bleeding on HRT. I thought it was worth just highlighting at the end as well about the well, it's not new now, but it's been out a little while, the unscheduled bleeding on HRT. So anybody on HRT under 60, there is that separate guideline that's available on the portal to do with scanning and the endometrial thickness cut-offs for whether you're on cyclical or continuous. So just to be aware that that exists. So if anybody's on HRT over 60, I think it's refer anyway, but under 60, we can do the scan and look at the guidelines as to whether they need more investigations. So just to remind people of that as well. That's brilliant. That's been really useful, Monica. I think we've covered loads in a short time. Yeah, that's fab. So thanks again for doing another podcast for us.
Thank you.
Brilliant.
Thank you very much.
Bye.
You.